So let's switch gears yet again, and we're transitioning from the kind of targeted therapies and targeted populations. You brought up the question, Jeff, do EGFR TKIs have any merit in an EGFR wild type population? And we saw, and I asked Mary Jo to comment on this, we saw the Lux-Lung 8 trial this year where in a second-line squamous population, which is almost universally wild-type EGFR, a comparison between erlotinib and afatinib, with actually, at least to me, surprisingly positive overall survival data that was reported, secondary endpoint, but yet survival was better. Your thoughts?
It's true, the survival was better, and the progression-free survival was better too, using afatinib, which is an irreversible tyrosine kinase inhibitor directed against EGFR, versus erlotinib, which is a reversible, first-generation EGFR. The numbers themselves were a little bit underwhelming, and I have had wild-type patients. I know they're wild-type, and they've benefited from first-generation TKI, sometimes for a year or two. But the problem is we have no way currently to select who's going to benefit. And if you look at all comers, the progression-free survival data is still not so high. So my take from this trial was that if you're going to try using an EGFR targeted agent against squamous cell cancer, then afatinib was a winner, and pick that over erlotinib because there was a PFS benefit and there was an overall survival benefit, and it was statistically significant.
Roy, do you use EGFR TKIs in the squamous second, third line space?
Not often. I've traditionally been a believer that these agents really work best in the mutated patient.
Right.
But the data from that trial, I think were compelling. We actually wrote the editorial on it.
Yeah.
And, I think the clinical trial showed a benefit, and there are very limited options in the squamous cell space. We have our lung map trial where we're looking for new targets, but even with that, it's hard to find, genetic-driven targets in that setting. So certainly, now we have immunotherapy that I guess we'll talk about later in our panel, but, people feel that too, or they're not eligible. I think if someone has a reasonable performance status, afatinib is your drug.
Yeah, I was just going to ask you that. Would that be your TKI of choice in this setting, based on Lux-Lung 8?
Based on Lux-Lung 8, yes. Now, and then dose reducing it and treating the skin and the GI toxicities as need be.
Yeah, it was amazing. It was not amazing to me, but one of the surprising things was, I think we had the general sense that we may expose patients to a bit more toxicity with afatinib versus erlotinib, and at least in this phase 3 trial, I didn't think there was, major differences.
It was not that dramatic.
Partly that's because they were only on the afatinib on average for a couple months. All right, and some of the side effects do accumulate over 3, 4, 5 months is when you start to develop the paronychia.
Right.
So that's a slightly different population than we're used to. I think the patients I think of for oral therapy for squamous is the person who's like, I don't want to be showing up weekly for gemcitabine or vinorelbine. Come on, is there some way I can just go home and take my pill? Right?
Yeah.
And that's not most of my patients in Massachusetts.
Right.
But I appreciate that there are some practices who have those patients who don't looking to travel weekly,
Right.
and that's where you create an oral therapy option.
Right, this is why these patient-reported outcomes are so critical. Some people say, why do we need any more of this? But in drugs like this, where the differences are really small, you have to look at quality of life and how patients are feeling and how they're doing.
And as Roy mentioned, we'll get to immunotherapies in a second, and certainly for the squamous subset of patients, this is a real advance. But we don't have a lot of options in the second, third line option.
Yeah, you have a slide. Mark has a slide where he says new drugs for squamous cell lung cancer, and then he puts up a blank slide. Right? That's what you.
Yeah.
Not anymore, but
Yeah, not
it's
anymore.
changed,
Yeah,
but that's what it was like a year ago.
Times have changed. Yeah. And speaking of that, I want to get Roy's perspective. I think you also wrote the editorial on the FLEX trial. So in your PI of the SWOG trial, looking at cetuximab.
Right, we're actually going to present that at the World Lung Conference.
Good. So we now have another EGFR antibody, necitumumab, that was recently published. It was an agent that was explored both in non-squamous, the INSPIRE trial, which was negative, but the SQUIRE trial in squamous in combination with cis-gemcitabine was a positive trial for overall survival. Maybe you could argue a little more robust than FLEX, but not markedly so. Give me your thoughts on necitumumab.
Yeah, I so much want to like this drug. The development of this has been over a decade.
Yeah.
Initially it was the ImClone drug, the fully human EGFR antibody, and it's made its way to a number of phase 3 trials, and of course the square was positive. Now I've been involved in some of the ASCO meaningful outcomes work, and the hazard ratio I believe here was what, about 0.8?
8.4.
8.4.
Yeah.
So a modest benefit, but again, it's in this frontline squamous cell lung cancer setting, comparing it to cisgem. Part of the issue also is that there was concern about pulmonary embolism and toxicity because the other trial was stopped. The trial in the non-squamous was stopped. With that said, that there is a benefit. I'd love to find some biomarker that could help us determine maybe a group where the hazard's in the 0.7 range.
Yeah.
Now, and those data are emerging now, looking at maybe EGFR gene copy number by FISH. We've run a large trial through the Southwest Oncology Group, SWOG 0819. I'm sure you've put patients on it yourself. And
Still have people on it.
Still have people.
Yeah.
And this was looking at cetuximab plus chemotherapy versus chemotherapy, this being carboplatin paclitaxel. And we used EGFR FISH, actually Fred Hirsch, spearheaded this, from his work. And actually that trial is completed, and we'll be presenting it at the in Denver at the World Lung Conference. And we'll have to save that; it's embargoed until then. But one of the main analysis will be looking at those patients, and with 1,300 patients with a FISH rate of about 40% positive, there'll be a large population now to actually look at that and hopefully answer the question, can that be used?
Yeah.
As far as what we have now, this is under review now by the FDA. Hard to know which way this will go, but certainly as someone who sees a large number of patients, as do you, to have something, again, with immunotherapy on the horizon, realizing that might be for a specific group of patients, having something to offer some of the other patients, I think it certainly deserves consideration.
Yeah, and I must say, I think when you looked at the IHC data and the H-score with Flex, it was promising, but never really came to fruition. When we looked in the Squire trial at the cut point that was defined in the Flex trial, the 200 cut point for H-score, there was no interaction with treatment in that particular setting. So I agree with you. With an antibody, you should be able to identify a biomarker that tells you who the patients that are benefiting, and more importantly, who the patients that are getting no benefit from this above chemo.
One of my questions is with nivolumab and immunotherapy coming, and changing the care for squamous lung cancer, is that going to move the bar more than this hazard ratio of 0.84, right? And does that hazard ratio get diluted out by such more powerful therapies that are emerging?
Maybe, but again, it's going to depend if there's selection. I've always been struck, I was going to ask the panel what you think. When was it that Flex was a plenary at ASCO? Was it 2009? So it's a while back, and it was a plenary talk by Robert Perker, and the hazard ratio then was what, 0.87?
Yeah.
So a little bit further north. And that never moved. We never saw an approval of this. And cetuximab, it's being looked at in other settings. Of course, it's approved, for GI cancers, but really never got any headway here. We're a little bit better with this. Perhaps a little bit easier to give antibody because of some of the issues with toxicity. But it'll be interesting to see. But I do agree. H-score, a bit disappointing here. Could EGFR FISH be a little bit better? It's slow progress.
Is there a patient in your practice where you would consider using, say, cetuximab at this point?
Well, again, we'll have to see what the results look like from the 0819. But I think, yes, if I had someone with untreated squamous lung cancer, my first reflex now would be to see if I could put them on immunotherapy. Have to look and see if they meet the criteria. Most of the trials with immunotherapy are requiring patients to be PD-L1 positive, a difficult biomarker in any respect. But if they're negative, to offer them this versus, the same chemotherapy we gave in 1998, I'd consider it.
So this is currently under review at the FDA. The FDA convened an ODAC meeting and interestingly took a different strategy, didn't ask for an ODAC vote, but kind of asked for if you read the medical letter, it was a thumbs up or a thumbs down kind
So
of
should we do that here now on our panel? Close our eyes and put our thumbs up?
That's right. But reading through the medical letter, it seemed like most of the ODAC members were kind of in favor of it. Was that your impression, or?
Yeah, again, I read the same letter as you, but it was an interesting discussion. But my sense was that the gist was that there was more in favor than not.
Right.
But the hope will be we can even find drugs in the future that are more of a home run, so that we don't have to sort of resort to this type
Do
of
the yay, nay,
be,
thumbs up,
be right
thumbs
on
down.
the border.
And I think the frequency of coming into clinic is important for some patients to come in for cetuximab once a week. I'm sure you can stretch it out to every 2 weeks safety-wise, but I feel like it can be a little bit more toxic. Could be a lot of back and forth for people.
Yeah, at least Neci is not a weekly drug. It's a day 1 and 8 drug, so that's a little bit of an advantage. But this side of the table,
I'm not a fan.
not a fan.
Yeah.
Yeah, I don't think it shifts the bar enough to be a standard part of my practice. I want something better, as Roy says.